So, women's health topics. That's going to be how we kick off the summer. There's 7 or 8 modules, I think. Not a whole lot of content, and a lot of the drugs we've already talked about, with the exception of this lecture, more or less, is going to be new stuff. But some of it's going to be review stuff. And then the syllabus, I haven't fully updated it yet with the test dates because Christy and I were still working them out. I think we've got them locked in. I just need to confirm with her on one thing quick. And I think it's going to be June 2nd for your first exam, that Monday. And she's going to be proctoring that for you. So I'm not sure what time it'll be, but I'll let her figure that out. And then the final, I think it's during your normal finals week, but I can't remember, again, which day. I think it might have been Tuesday we agreed upon. So anyway, I'll update that with those dates specifically, and we'll go from there. So anyway, without further ado, this lecture is basically going to focus on 2 things: contraceptives and hormone replacement therapy, and a couple of other random topics. We'll touch a little bit on breast cancer and some other topics like that as well. Okay, so more than 80 million women use oral contraceptives, a highly reliable form of contraception when taken correctly. So that's the big caveat here, and I'll show you some charts comparing those things in a second here. But with perfect use, an oral contraceptive has about 0.1% chance of failure. So quite reliable, and as reliable as any other method we have. With perfect use again. However, it requires somebody to actually take it perfectly, which humans are, of course, fallible, especially when it comes to taking medications. So missed pills, failure to resume therapy appropriately, taking pills on off schedules and things like that can increase your chances of failure significantly. So with typical use, studies have shown that most people have about an 8% chance of pregnancy or contraceptive failure in day-to-day use with the oral contraceptive. So it kind of takes it down a lot from the ideal 1.1%. Injections or IUDs are much more reliable. So obviously compliance isn't an issue if you have an IUD or an injection, and you don't have to worry about taking the pills day to day. IUDs, of course, can last several years, and depot injections you have to come back every so often for them. Rings and like the NuvaRing and the OrthoEvra patch are options as well that have actually pretty similar typical use failure rates as oral alternatives. Again, I'll show you a slide comparing that here in a second. Most products on the market that are popular are combined oral contraceptives, so they contain both a progestin and a estrogen compound. And hormonal amounts have decreased substantially since the 1960s when these first came out. So when they first came out, much higher levels of hormones than what we're seeing today, especially with respect to the estrogen, which is ethinyl estradiol component, has gone down substantially over the years. So this slide shows you this comparison of typical use versus correct use. And again, typical use would be, correct use would be assuming that somebody used the contraceptive method exactly as prescribed, whether it's a condom or a pill or whatever, every single time. Typical use would be how people use them generally. So again, with the human fallibility rate in there. So you can see that there's several methods put on here. And the only thing that is going to show you the same on both would be a intrauterine device or an IUD and your sterilization method, so like vasectomy or female sterilization. And the implant as well has very high typical use reliability. Okay, so let's talk about the drugs that are in these contraceptives. The estrogen component is ethinyl estradiol. It's going to be the estrogen component in every single one. So it is a little bit easier to remember since the progestin component changes substantially. So there's probably, 20 or 30 different synthetic progestins on the market, and ethinyl estradiol is going to be the constant in all oral contraceptives. However, the dosing is going to vary. So standard dosing is going to be up 30 to 35 micrograms. I don't care that you know that, just for reference. Some of the lower products, so like when Ortho Tricycline came out as a very popular brand name birth control, and then they came out later with an alternative of it called Ortho Tricycline Low, which dropped the estrogen or the ethinyl estradiol to 25 micrograms. And then there's some products on the market that have even lower, like Lolestrin as a product too. It has 10 micrograms. And we'll talk about the advantages of those here in a few slides, but just keep that in reference. So you do have some flexibility with your dosing of estrogen. If you have somebody experiencing side effects due to too high of estrogen, they could take a lower dose product, and hopefully that's going to alleviate that. And again, we'll get to that here in a second, so bear with me. The progestin component, there's a lot of them. These are just some of the common ones out there, but there's, again, several of them on the market, 10s, 20s, 30s. How to tell when the progestin component is, again, if you're reading a label on a birth control or you're typing in a prescription for one, it's the one that's not ethinyl estradiol, right? So it's going to be that other one. Also have residual androgen activity. So Progestions are derived from testosterone, and some have much more androgen activity than others. So, for example, we look at progestions in the combined oral contraceptives, your first generation, second generation, third, and this sort of goes hand in hand with how much androgen activity they have. Generally speaking, the later generations have tried to push towards a lower androgen activity, but that's not always necessarily true. So this is a little bit more of a useful slide if you're looking at generic names, thinking, well, my patient is having maybe a lot of acne or bloating or something like that. Maybe more weight gain potentially, not necessarily totally linked to testosterone, but it's, or androgen activity, but it's possible. You could look at decreasing the androgen activity. And a drug, the specific drospirenone, which is the progestin component in Yaz and Yasmin, the really popular birth control options, that is considered an anti-estrogen by the drug company, but technically it's just sort of androgen neutral. It shouldn't really have an androgen effect at all. So, but it's classified sort of, if you're going to put low activity, high activity, middle activity into pools, we just put it with the low ones. Okay. Okay, estrogenic mechanism. So how do these drugs work? So estrogen, by supplying the female with estrogen, you're going to suppress hypothalamic gonadotropin releasing hormone, or GnRH, and pituitary gonadotropin secretion. You're going to inhibit mid-cycle luteinizing hormone surge, so you're basically preventing ovulation. And so if you give somebody a progestin-only pill, which those do exist, and we'll talk about where those might come in handy, you miss that part of it. We'll talk about where progestin comes into play and why it's useful on its own, but you would miss that if you're not, if you're doing an estrogen-free product. Suppression of ovarian folliculogenesis and suppression of ovarian steroid production are two other mechanisms. So you've got a few mechanisms already with just estrogen alone. Progestin products have effects on the endometrium, so they can render it less suitable for implantation, which can cause some atrophy over time. You get alterations in cervical mucus, which decreases permeability to sperm, and impairment of normal tubal motility and peristalsis. So several other mechanisms that work complementary to estrogen. So when you think about, I think some people think, well, maybe not you guys, because you guys are smart, but I'm not saying people don't think this is smart. People who don't necessarily know a lot about how this all works might think, well, oral contraceptive just prevents me from ovulating. It's much more complicated than that. So that's all I'm getting at here by talking about the mechanisms. There's a lot more going on to contraception than just prevention of ovulation. And you guys have probably all seen something like this throughout your careers. In case you're wondering about the hormones and the spikes and stuff that I just referenced, there's a chart for it as well, but I'm not going to go through it again. So when we're talking about starting somebody on contraception, you're looking at a couple different options. So this is UpToDate's recommendation, which is a little bit confusing. So some of the easy ones I just bulleted on the side here. So one of the popular choices for starting, we'll go through the UpToDate chart here in a second too, but Sunday start the pill on the first Sunday after a person's period begins, and use backup contraception for 7 days following. That's a pretty standard way to start it. It's simple. Most people can understand it. And then after 7 days, they should have finished their period, and then they should have full coverage from the pill, and shouldn't have to use any type of backup method. The other way to do it is the first day start, which is to begin the pill on the first day of menses, and backup contraception is not needed then. So that is the other way you could do it. UpToDate goes through some options, and the big things that they're throwing in here are things like urine pregnancy tests. So for example, if you can confirm that the patient, the last menstrual period was less than 5 days ago, you can start the method today, use the backup method for 1 week. So that's pretty similar to your Sunday start option, not all that different. If the last menstrual period was greater than 5 days ago, that's when you'd want to do a urine pregnancy test just to make sure. Now, your patient might tell you that they aren't sexually active yet or whatever it may be, but technically I think you're supposed to do it anyway. And if they had unprotected sex since the last menstrual period, that would put you to different stratification after that. So it depends on when the patient wants to start the method. So I'll give you that to think about and just to look over on your own. I'm not going to ask you too many details on this. What I would like you to understand is that if you're starting it basically outside of this first day start scenario, you do have to use 7 days of backup contraception. That's kind of my big take-home point here. Yeah.
And the 7 days after, so just like the first time surgery?
Yep. Right, yep. So once you do that, then if you're on it, you're on it. You would need, assuming you aren't having any breaks in therapy. Other types of contraceptives can be started basically anytime. A copper-containing IUD, for example, doesn't need to be backup contraception. You can actually use a copper-containing IUD as an emergency contraception, and it can cause spontaneous abortion by itself. And levonorgestrel releasing IUD would be a product like Mirena. There's actually several brand names on the market right now, which I'll talk about in a couple slides here. But that's another one that has a 7-day backup period as well, or abstinence for 7 days. The implant, injectable, and combined, it's very similar across the board. You can see here how you're going to start them all. So basically the copper IUD is really the only oddball in the group. Tablet packs. So if you've ever seen a birth control pack, you know that they all kind of look similar but different. And what is different about them usually are the color schemes that the drug companies will choose to use. So generally speaking, a standard oral contraceptive is going to have 4 weeks of active pills and a week of placebo pills. And the placebo pills are usually specifically a different color. So sometimes they're white, which I think makes sense. But sometimes they're, a red color, I guess, on here. But it doesn't really matter as long as there's some sort of differentiating factor there. This product tried to change the color of it. Where you get a little bit more creative color schemes is something like this. This is like an orthotricycline brand product, so you have different variable dosing, so the dose actually changes, which allows the product to be as effective, but gives you overall lower hormonal exposure. So theoretically, you have less side effects with it, with a cyclic product versus another one. We'll talk about those here in a second, where you might want to use those, but that's just what that's representing. And then this would be an example of an of a no placebo type package. So some products do have that. They're designed to take continuously, so you might take them for 3 months in a row, stop, and then start up again after a week if you want to have your period. And some people might take them continuously for longer periods of time than that. Just depends on the patient and what type of scenario they're in, and why that might be useful for that person. All right. So talking about instructions, normal use, what do we mean by normal use? Take it at the same time every day and don't miss doses. That's really what it comes down to. And of course, people will miss doses, people will forget, people will go on vacation and forget their birth control at home. That kind of stuff happens. So the question is, what happens if you miss a pill? So if you miss a single pill, you want to take your other pill as soon as you notice, even though that means taking 2 pills together, and no additional contraception is needed at that. I mean, theoretically, your risk does go up a little bit, even with a single missed pill, but it's not thought to be significant enough where you would warrant backup contraception. If you had somebody really concerned and they're like, well, I want to do it anyway, is that wrong? No, absolutely not. I mean, you could use backup contraception throughout the whole time you're on oral contraceptives as well, and certainly if your patient's at risk for STD exposure, that would be probably a good idea to use a barrier method at the same time. There's certainly no problem with that. It's just you don't technically need to do that based on the guidelines and recommendations. So if you miss 2 or more pills, then you want to take the one missed pill, not 2, so keep that in mind. 1 missed pill as soon as noticed, and then continue the regular cycle. If the pills are missed during days 15 to 21 of a 28-day pack, you want to finish the pills, start a new pack, skip the placebo pills altogether, and then use backup contraception for 7 days. So it gets a little more tricky once you miss more than one. If you miss a whole bunch of them in a row, you're basically going to continue something like this, and it's sort of like restarting, right? You're just restarting, skipping placebo, and you're going to use backup contraception for 7 days.
That's 2 or more missed pills in a row, not like this Monday and then this Friday.
Yeah, that's a good question. If you have a patient coming into you and you realize they missed a bunch of random ones during the month, I think you probably want to see if they were consecutive or not, and if they did make them up. And in that case, you could consider just having them restarted. I would probably, and then of course, reinforce education. I did have a patient one time when I was an intern come in and talk to me about her refills or something, and she wasn't actually taking them scheduled. She was taking them as needed every time she had sex. So there are people out there that just sometimes don't get the concept of it, and so making sure people are educated is always best.
If you're restarting it, do you need to wait for their max menstrual period or to restart, or can you just start again?
No, you could just start again, and as long as you skip the placebo pills, they might get some spotting or abnormal bleeding, but you theoretically would skip the next cycle if you did that way. Yes?
Is it true that there's a higher chance of pregnancy when you stop birth control?
That's a good question. I think that's kind of an urban legend. I've heard that from people, and I haven't found good evidence to back that up, though. So, Extra pills. So if you accidentally take some extra ones, just resume your normal schedule. Don't skip a day if you take 2 in one day. Return of menses within 30 days of stopping the pill should return, and if not, by 90 days. So this kind of goes to your question about fertility returning in greater abundance, perhaps stopping the oral contraceptive. You should theoretically you have a window of time where your body is going to get back to normal. So if you think about it, it takes up to 90 days potentially for some. That should delay the fertility period for some time. But yeah, you can definitely get pregnant right off the pill too. So it's not uncommon for people to start ovulating right away. Yes.
If a person gets pregnant while they're taking the pill, so like they have the missed or something, is it teratogenic or
not really? It happens probably, of course it happens fairly often, so it's just something you'd want to stop right away, but it's not, I don't think it's listed as a teratogen. I don't think the fetus is as exposed, is problematic to get exposed to hormones that early. I think it's later where you'd be more concerned. So generally I think it's just you stop as soon as you can and hopefully things work out okay. All right, types of oral contraceptives. So there are 2 different, there's a couple different ones, but the common ones are 21 and 28 day cycles. So 21-day packs simply don't have a placebo pill. It's not like they're really all that different than other ones. So it might be more advantageous for somebody to get a 21-day pack if they're skipping their placebo pills. Some new packs only have 4 days of placebo, so they have maybe a lower dose of hormones altogether, and then the placebo is shorter because it doesn't need to be as long. You can get a period or start a new pack or take you can get a period and start a new pack or take continuously and skip menses altogether. Again, this is going to depend on the individual patient. So menstrual symptoms may improve with this strategy if somebody has really problematic symptoms associated with their menstrual cycle. That could be an option for them to help relieve those symptoms. And you do see more breakthrough bleeding with this overall, though, because when you get exposure to progestin over time, you do get the atrophy that can cause the breakthrough bleeding in the endometrium. So that's what the big side effect is. So that's why taking some sort of a placebo break at certain periods of time is generally going to be better for the patient than going. That's why people don't generally take oral contraceptives for like a year straight with no placebo. You could do it, and it would be effective, but you're probably going to get a lot of breakthrough bleeding due to the atrophy over time. Mono versus multiphasic. So I alluded to this earlier. Monophasic contains the same dose of hormones throughout the pack. Multiphasic is an attempt to lower steroid dose. So again, tricycline or tri products. There's a lot of products out there that are branded like this. Usually the estrogen dose is fixed and the progestin is the variable product. There's no proven clinical benefit to doing this, and again, it's a better tolerability thing for patients experiencing side effects. You may want to try it and get lower overall hormone exposure with no decrease in efficacy is the theory behind between a cyclic product. Okay, so what kind of side effects are we talking about? Why would you want to consider some of these different strategies? Well, they vary widely based on type, dose, and route of the contraceptive. So generally speaking, most oral contraceptives are going to have a couple side effects associated with the different components. So estrogen, bloating, nausea, and breast tenderness are the common ones, especially when people first start taking oral contraceptives. They usually should subside over a few months. The big one that gets people nervous is venous thromboembolism. So higher estrogen doses are associated with a risk of venous thromboembolism. But risk is prevalent with both low and high dose products. So it's not like if you go from high estrogen, like a 30, 35 milligram high, in parentheses, to a lower product, like a 20 or a 10, you're not really going to decrease your risk. Estrogen exposure sort of is going to put you at a slightly higher risk than the general population, no matter really what the dose is. However, it is quite a bit lower than somebody who is pregnant or in the postpartum period. So pregnant postpartum patients, if we look at this stat here, this 3 to 13 per 10,000. Pregnancy and postpartum, it's about 70 per 10,000, so it goes up substantially. And for youngish, healthy women, you're looking at about 3 to 13 people per 10,000 will experience a venous thromboembolism while taking oral contraceptives. Now, things can make that increase, like a thrombophilia disorder, specifically factor V Leiden, can make you at much higher risk for getting a clot. And that's not something that's routinely tested for unless you know you have that genetic variant in your family history. So that could be something that somebody gets a pulmonary embolism or a DVT, they come in and they get tested for it, and sure enough, they're on an OC and they had factor V Leiden positive, whether it's homo or heterozygous. So that can, of course, increase your risk. again, just keep this in mind. We're going to talk a little bit about some of the controversy with some of the products. There's been some lawsuits and some class action settlements and things like that related to the VTE risk that increases with oral contraceptive use. So we'll come back to that in just a second here. Cancer. So increased risk for cervical cancer slightly, and mixed data on breast and liver cancer. I think they're generally thought to be low enough risk where the benefit of the contraceptive outweighs the risk of getting cancer. Yes?
Do you know if there is decreased risk of ovarian cancer?
Yes, there is. I think I've got that. I think I talk about that a little bit more with hormonal replacement therapy, which is similar but slightly different to this. So I'll come back to that if I don't. Remind me. Side effects and risks. Okay, so continued things. Weight gain is something that I think commonly gets pegged on oral contraceptives. It's inconsistent data. The only product that I know for sure has pretty solid weight gain evidence is the Depo-Provera IM shot. That one's got fairly consistent data that it does cause increase in weight gain. The rest of them, and it just depends. And I think a lot of patients will experience different weight gain with their products. So again, statistically, it's not a significant side effect, believe it or not. Breakthrough bleeding, again, most common form side effect of oral contraceptives reflects a breakdown of your endometrium. Possible causes: missed pills, lower estrogen doses. So estrogen stabilizes the endometrium. So this is where playing around with your estrogen dose can be handy. Granted, on one end, you can lower your estrogen dose and probably get away with an effective contraceptive, but you might get a patient who has a lot of breakthrough bleeding with one of those really low dose products. So a higher dose estrogen product can help stabilize the endometrium. Now again, there's that theory that maybe even slightly higher estrogen doses cause increased risk of VTE, but that's not proven. And overall, again, your risk of taking estrogen, are you looking at the 3 versus the 13 side of the spectrum? That's kind of how I see it. Or let's look at let's take out those outliers and say, let's say 5 to 10 per 10,000 people get a VTE. If you take a low estrin product, you might be on the 5 side or a 10 side. It's still a really tiny risk overall, especially again, if you're a younger, healthy female, you're not going to have a high risk. Stroke. Stroke's something that does have a pretty significant correlation when certain factors are met. Extremely low risk in healthy women under age 35 is essentially the same as the general population. Slightly higher in women over 35, but not high enough to give a contraindication. However, if you smoke and you're over 35, it's a contraindication. You aren't supposed to take birth control. So I've had some people, or I can't remember who talked to me about this in school, but like, yeah, if you have a patient who's over 35 and they smoke and they want to keep their oral contraceptive, well, once they come into your office for that visit, that's the time where you say, all right, time to quit the cigarettes. Like, use this as an opportunity to leverage that. I don't know if it's a really ethical thing to do, but that was that person's opinion. So I think that's kind of interesting. But the point is that that is considered a contraindication. There's a few other contraindications to oral contraceptives that have to do with bleeding or clotting risk. But the other big one that I think you might encounter, especially with this patient population generally looking for oral contraceptives being premenopausal women, migraine headaches also being a fairly common thing in premenopausal women. So migraine headache with an aura AA is a contraindication due to increased stroke risk as well. So you could consider other options, specifically like low-dose IUDs can maybe be an option for those patients, and I'll talk about those here in a second. Myocardial infarction. So you think stroke risk, maybe MI is a risk too. Actually, there's likely really low rates, if any, elevated. It's very mixed evidence currently, and we don't think that there's a significant increase with oral contraceptive use. All right, so anti-androgens, you might have heard of these. You've probably seen these products advertised on TV if you've watched any commercials within like the last 10 years. Yasmin, Yaz, and Bayaz are all really popular contraceptives. So basically, the difference between Yasmin and Yaz is the estrogen component. So you have a 20 versus a 30 microgram estradiol. So with Yaz, they dropped the estradiol component a little bit. Doesn't mean Yaz is any better than Yasmin. It's just, again, a lower estrogen dose. Bayaz is Yaz with folic acid added to it. So the reason why they did that is because they thought that if you're trying to get pregnant and or maybe you do get pregnant while you're on the pill, or you get pregnant immediately after stopping taking the pill, then you have enough folic acid circulating in your system that it helps prevent spina bifida long term. That's a stretch, and I would say that anyone who is even thinking about getting pregnant, even if they're on an oral contraceptive, should probably be on a generic over-the-counter multivitamin. You're going to get the same effect. So my opinion on Bayaz, it's kind of a drug company scam. and that there really isn't a place in therapy for it. I can't figure out why they can market it the way they do, because I think it's just a combo product that's solving a problem that doesn't really exist, that you couldn't solve by buying, a $5 bottle of prenatal vitamins over the counter. Associated with greater VTE risk when compared to levonorgestrel. So levonorgestrel is another progestin, and comparing it to drospirenone head-to-head, they've actually seen a statistically significant increased risk of VTE when compared with the other one. Now, the risk is still small. Again, you're talking about within that spectrum of normal OC VTE risk. So when you look at 3 to 13 per 10,000, again, norgestrel might be 5, and this might be 10 or 11. Again, not huge differences, but enough where people do get concerned. And like, well, statistically, if you look at all the people taking oral contraceptives, yeah, you can correlate that data and find a statistical significance. Is it clinically relevant? I don't know. Would you say are people still taking these products? Yes, they certainly are. So again, it's maybe a little bit increased risk, but I don't think it's as blown out of proportion as you might see in the media sometimes. The anti-androgen drospirenone is marketed as causing bloating, acne, weight gain, and helping with PMS-related symptoms, which were the previous term. What they call it now, premenstrual dysphoric disorder. Is that what it's called now? Okay, so that was kind of a thing that came about, I don't know if I can give Yasmin credit for inventing that term, but it probably came about the same time, where they got in trouble because they were marketing it as helping with certain menstrual-related symptoms that it really wasn't qualified to do that. So they came back and they kind of invented their own term, from what I understand. Now we actually use that term in practice, so I don't know what came first, the chicken or the egg. But the point is that it does help with mild, we'll say, menstrual dysphoric symptoms. Anyway, Yaz and Yasmin are super popular birth controls, so it's good to know a little bit more about them than maybe the average birth control. Whoops, got a thing popping up on my recording here. There we go. Okay, we talked about some of these contraindications. Remember, age and cigarette smoking, some multiple risk factors. Hypertension, if you have uncontrolled high blood pressure, that's a contraindication. Talked venous thromboembolism history, which would make sense. Ischemic heart disease, history of stroke. Lupus, migraine, breast cancer, cirrhosis, and possibly liver cancer as well. All right, so drug interactions. So if you get something that interacts with your oral contraceptives, it could be problematic because you don't want your patient to get pregnant if they aren't trying to, right? So this is kind of important with this. However, take some of this with a grain of salt. So these steroid hormones in general are CYP metabolized through various cytochrome P450 enzymes. And when it comes to enzyme inhibition, we generally aren't concerned. So for example, azole antifungals and drinking a ton of grapefruit juice might actually cause higher serum estradiol concentrations. It's not going to decrease the efficacy of your contraceptive, could put you at higher risk for venous thromboembolism. So probably okay if you're taking a one-time dose of fluconazole. Maybe if you're going to be on fluconazole long-term for something else, or if you really love grapefruit juice and you're drinking gallons of it a day, it might be a problem. But rarely are people doing that, right? In general use with grapefruit juice and azole antifungals, I think you're fine. Enzyme induction may decrease efficacy. So if you're increasing the enzyme's ability to metabolize the product, you're going to get lower serum concentrations. So phenytoin, carbamazepine, phenobarb, rifampin are the big enzyme inducers. So really for somebody who has epilepsy would probably be the biggest thing here. And if they're on phenytoin would be the most common thing you're going to see. Carbamazepine, again, just not a super common anti-epileptic drug, sometimes used in bipolar, sometimes used for neuropathic pain. So you might see it in those arenas as well. But again, none of these drugs are super common. Phenobarb is rarely ever used on a regular basis anymore. And rifampin would only be synergy in odd ID cases and sometimes in tuberculosis cases. Okay, antibiotics. This is one that comes up a lot, and it's kind of controversial. Generally speaking, it's okay to combine the two. The reason why there's controversy with antibiotics and oral contraceptives is that sex hormones undergo enterohepatic recycling, and your gut flora is critical in this process. So when you excrete sex hormones out, your GI flora modify them slightly, and then you can reabsorb them, getting more use from them. So they recycle, keeping their half-life going longer, which is why you can take them once a day. Now, if you wipe your GI flora out of anything, so if you're taking broad-spectrum antibiotics or any antibiotic, really, you're at risk for possibly disrupting this. So that's the theory. Clinically, it's not really proven. that this has a big effect. So generally speaking, it's thought that antibiotics are mostly okay. There are some antibiotics that can affect the CYP enzyme system as well, but most of those are going to be on the inhibition side and are going to increase exposure versus increase enzyme induction, right? So we're looking at possible increased risk of side effects, not necessarily decreased efficacy. Now, if you have a person who's taking an antibiotic and they're really worried about it and they want to use backup contraception, great. No problem there. Again, you can do that without issue. If they want to use a barrier method for a week or so while they're taking their UTI course, fine. But statistically, they haven't shown that that actually increases your risk of pregnancy being on an antibiotic. So yeah, kind of a risk always benefit, but I'd say the risk is quite low. Other things, St. John's wort may induce the CYP system, so that's probably one that I wouldn't recommend taking with oral contraceptives in general. And HIV drugs have a mixed bag. So if you have an HIV patient or work with that population, that'd be a person just to run an interaction test on and make sure nothing's significantly interfering with the oral contraceptive regimen. Okay, what about non-oral hormonal contraception? I'm sure most people here are familiar with NuvaRing. It's pretty heavily advertised, kind of a novel drug delivery mechanism. I think it's kind of cool from a pharmacy nerd perspective. So NuvaRing is a combination product, so it's ethinyl estradiol and etonogestrel, I guess. Used intravaginally once weekly for 3 weeks and then 1 week without. You can actually take it out for 3 hours without losing any efficacy and rinse it with warm water and put it back in. The ring itself is a plastic polymer that actually leaches out drug, so it's not like it dissolves or anything like that. So again, kind of a cool method of pharmacology there. What you get is some systemic exposure and local effects too. So the local effects of the hormones are going to do the same things as a systemic effect, but you do absorb it quite a bit too. So actually, you would think that the side effects would be lower, but they have shown that the VTE risk is on the higher end of that spectrum we talked about. So there's recently a large Merck settlement class action suit that I don't remember how much it was. It's quite a bit of money where they sued because they weren't given that advertisement, I guess, with the drug, not saying that it is slightly higher risk. Even though it's normal, within the normal range of what we'd expect, it's still on the higher end of that. So they got fined pretty heavily for that one. The OrthoEvra patch is another combination product. It's got lower dose estradiol, and overall exposure, however, is quite a bit higher. It's about 60% higher. So if there is a product with increased venous thromboembolism risk, I would say it's probably this one. The reason is it's just the depot effect and the absorption through the skin. Steroid hormones are pretty lipophilic, so they can get through barriers quite easily, and it just shows that you have a higher blood concentration with this, even though the overall dose is lower. So why don't they go with a lower dose? I'm not entirely sure why they made that decision to do that, but there you have it. I've heard that there is a lower product in development, but I haven't seen it hit the market yet. But then again, I don't really follow patches that closely, so maybe it's out there. We don't really see this in the hospital as much as we might see. I don't think this is a super popular product compared to some of the other options out there. So what you do is you do one patch each week for 3 weeks and then 1 week patch free. It's not recommended for use in patients over 198 pounds. So if you weigh 197, you're fine. It's really weird weight that they pick, but basically you get a poor absorption and decreased efficacy. Just like any patch with a higher weight person or a low weight person, you're going to mess up the designed pharmacokinetics of that product. Remember, these products were probably tested on college students who have probably lower body fat overall, potentially, generalizing, but just to consider what they studied it on, they can't really guarantee you're going to get across the board efficacy with varying weight groups of people. All right, so this is just to show you the NuvaRing and the size. I don't know, when I saw one, it was a little bit bigger than I thought it would be. Patches, places you can apply them. There you go. Non-oral hormonal contraception continued. Depo-Provera is the shot that I told you about that has the highest weight gain association. It is a progestin-only product. There's no estrogen component, so it's not combined. It's an intramuscular shot you do every 3 months. The nice thing about this is, first of all, the adherence rate. You come in once every 3 months. It's also relatively cheap. So like when I volunteered at our clinic in the Phillips neighborhood during school, this was a product we actually carried on formulary because it's cheap, and again, you get 3 months out of it. And it was actually cost effective to 3 months of generic oral contraceptive, believe it or And then we have IUDs. So we'll talk a little bit about IUDs here. They're a pretty popular choice for good reason, I think. So there's two types, the levonorgestrel releasing, which are 4 different products on the market. So these are the different brand names of them. I think it's all the same drug. Now, Mirena and Liletta are the highest amount of levonorgestrel releasing. They're basically, think of like Mirena as the brand name, Liletta as the generic. It's one thing I didn't really talk about with respect to oral contraceptives is that the generic names are really confusing. A lot of times sure you get the generic name of the drug and you'll see it on the package, but like if orthotricycline is the brand name, the generic name might be like Nordet or something, or like usually they pick like women's names like Camila or Portia or things like that. That's what they name these things. I don't know. It's really confusing. It's nice when you're typing it into an electronic medical record because you don't have to like figure out what the progestin product is. You're just like, oh, I'm taking Nordet. You type in Nordet. Easy. So maybe that's the theory behind it. But anyway, they've come up with all these catchy names. So instead of calling their product like generic IUD number 6, they call it Liletta, right? Yeah.
For exam purposes, for generic versus brand name.
I'll kind of loop all levonorgestrel IUDs into one group, so I'm not going to ask you to know any differences in them. There's not very many contraindications to an IUD. There's really very little systemic exposure to the drug. In fact, if you look at studies, the side effects are very minimal. Basically, most people will get a little bit of breakthrough bleeding initially, and then after that, it's very side effect free for the most part. Now you do have difference in doses. So Kyleena and Skyla decrease the product a little bit per day. So like I was talking to Jeannie about this a while ago, and she was talking to me about like we were talking about the migraine aura thing and like what product do you use, and she was thinking that Skyla would probably be the best option for those patients because it's the lowest amount of hormonal exposure, and yet you still get an efficacious product out of it. But theoretically, any of them would probably be fine. Now, does 14 micrograms versus 20 micrograms a day make a huge difference? I don't know. I think this is just the way this type of medicine works. It's like, well, we started with 20 with Mirena. Now let's push it lower and lower and see how low we can get it with having, because, you know, the less drug you can have with the same efficacy is always going to be beneficial because you're going to decrease side effects. So that's the advantage there. So I think that's what we're seeing, and maybe we'll see that get lower as time goes on. IUDs aren't necessarily cheap. I want to say they're like $1,000 or so. Usually insurance pays for them, and again, you get about 5 years of use out of them. So affordable in the long term, absolutely. Copper IUDs can be left in place for at least 10 years, so a much longer period. Copper IUDs are a much older drug. They are associated with, so people, when they take an IUD, they do get a type of a mild version of a menstrual period, I would say. And it's not as heavy as it would be off the drug together. But it's not like you have to go through like a placebo period or anything like that with it. With a copper IUD, you would still get a generally normal menstrual period and a little bit heavier menses. So that's one of the big things that is the difference, I think, between the two. And people are like, well, should I choose a progesterone-containing one or the copper? That's probably where you'd ask your patient what they'd prefer. Also, copper IUDs, while highly effective and much more effective with general use than anything else, are very slightly less effective than a levonorgestrel. So you might get a couple more pregnancies per 1,000 patients than you would with a progesterone-containing one. So again, that's very slight, so I don't want anyone to take that to the bank, but just an option worth talking about. Mechanism of action of intrauterine devices. So again, these are working mostly locally, changing the cervical mucus that inhibits sperm transport. This silly picture I put up here. I was trying to figure out not everyone knows how big a uterus is, right? So it's like, let's find something that compares it. And it's like, well, this is a pretty good size comparison, I guess. I don't know why. I'm pretty sure somebody photoshopped that onto there, right? It's not an actual person with IUDs on her tongue, but you never know. So anyway, they're all about the same size, and they're designed to fit in the uterus like so. What else is there? So there's, again, some effects here. Very similar to oral contraceptives, not a whole lot of different things here. They aren't going to really do much to change ovulation as much, but they're going to prevent implantation and cause more direct ovicidal effects. All right, hormonal contraception uses benefits outside contraception. So if you're taking oral contraceptives and not taking them for the purpose of contraception, why would people do that? Well, hyperandrogenism, usually due to polycystic ovarian syndrome, can be mitigated using oral contraceptives. Dysmenorrhea, menorrhagia, hypothalamic amenorrhea, female primary hypogonadism, so it's basically a hormone replacement strategy, premenstrual dysphoric disorder, which you talked about a little bit, acne treatment, hirsutism treatment, decreased cancer risk. So endometrial and ovarian and colon cancer have all shown decreased risk overall. So if you have a patient who comes from a family with really high colon cancer, ovarian, or endometrial cancer risk, you might consider putting them on it earlier in life, maybe even before they're sexually active. And again, it's a risk always benefit type of scenario, but it's certainly something to be considered. Okay, use during lactation, of course, very common question your patients are going to get. They had a child, now they want to go back on some sort of contraception. What can we use? Hormones excreted in breast milk may pose a risk to the infant, in addition to estrogen decreasing overall breast milk production. So generally speaking, lactation barrier methods are preferred. However, you can use some things. So progestin-only pill, the mini pill is the brand name of that, can be an option. It doesn't appear to affect breast milk production. However, because you don't have the opposing estrogen, you do get more breakthrough bleeding with that product. Depo-Provera, again, similar thing. It's progestin only, and you're going to get the same side effect of breakthrough bleeding with that. IUDs, probably if you consider it, if you're looking at breastfeeding for like a year or so, that's probably the best option for most patients if they're open to it. And you can insert a levonorgestrel product 4 to 6 weeks postpartum. The reason is the hormone releasing locally can have an effect on the uterine lining while it's still a little bit stretched out. And so in that case, you can have a perforation potentially. So that's why you wait 4 to 6 weeks to make sure things have a time to bounce back a little bit before you would put an IUD in. Yeah.
With IUD, you said that most people get like a smaller period, but what's the difference between that and the breakthrough bleeding?
Yeah, breakthrough bleeding would be, from what I understand, a little bit more random, and it would be more associated with onset of the medication. So like if you take the progestin right away, you might get some immediate breakthrough bleeding. Your body might get up to it. Or alternatively, the longer you take it, the more breakthrough bleeding you can get. That would be not necessarily associated with any type of a pattern. It would start and be continuous mostly. It wouldn't like stop after a few days. Where with IUD, you'd probably start and get maybe 3 to 5 days of light bleeding and then be done, versus like a full period. Okay, emergency contraception. Candidates, people who have had recent unprotected intercourse or recent contraceptive failure, whatever reasons those may be. High-dose progestin was the product that came out as Plan B, which I'm sure everyone here has heard of. It's a levonorgestrel, and it delays ovulation. It's much less effective in obese women per studies. So actually significantly less, so that we prefer to use ulipristal now, which we'll talk about in a second. And also, you don't have as big of a window with Plan B, so it's about 50% effective after 72 hours. It is pretty effective if you take it within like 24 hours of unprotected intercourse. It's more like 80%, but it does diminish substantially. Whereas Ella, aka, well, people were like, what do we call this product when it came out? And so everyone is jokingly calling it Plan C, because Plan B is so catchy, right? So it's actually brand name Ella, which is kind of funny because it's a really popular girl's name right now. But that's the emergency contraceptive on the market. Ulipristal is the brand name. It prevents progestin from binding to the progesterone receptor. So it's a different product. It's not necessarily a direct hormone, and which delays ovulation. Data shows high efficacy that's sustained for 5 days, and also better efficacy in patients over 80 kilograms. So you have 2 great reasons to use Ella versus Plan B, which is why, like, to bring some sexual assault type stuff into this, that's what I mostly see patients for in my ED practice, and this is our standard drug we give them. Yes.
What if you just ovulate?
That's a good question. I don't know if it would mess with implantation at all. Yeah, I'm not sure about that one. Good question. And you can insert a copper. Maybe that would be like a copper IUD would be 95% effective, because that would be ovucidal, so that would prevent most potential implantation option. Non-steroidal anti-inflammatory drugs, or NSAIDs, like specifically misoprostol, have been used for this in the past, but that's not as common of a practice anymore now with the newer products. All right, we can take. Oh yeah, sorry.
I have a question. Are there any like side effects if you repeatedly take it? Anything like that?
Yeah, it's a higher dose, so you'd probably get a lot of breakthrough bleeding with it if you repeatedly used it. Yep. Yes.
How permanent is the atrophy with like the progesterone hormone?
I don't know. That's a good question. It would go back once you stop it, or if you gave an estrogen product to oppose it. But I'm not sure how permanent it is. It probably depends on how long you've taken the product for. And that brings up a good question, or a good point that I just thought about. You can actually take, like, I don't know, it depends on what dose of oral contraceptive you are, but you could double or triple up on your current oral contraceptive and get the same amount of progestin product as you would get with a Plan B. Sometimes people who don't have access to something, who maybe have an event like that, you can't get to a pharmacy or don't want to, that could be an option for them. That is ideal because you're taking a bunch of estrogen too, but that would work the same way, because really all Plan B is a higher dose of progestin. That's all it is. All right. Let's take a 10-minute break and come back and talk about hormone replacement therapy. With hormone replacement therapy, we're going to talk about very similar drugs, basically the same type of drugs, just used in different contexts for the most part. So talking about menopause and the perimenopausal period, about 95% of all women will experience menopause between the ages of 45 and 55, officially defined by cessation of menstrual periods for 1 year of time. And then treatment during menopause, basically we're trying to help with symptomatic relief, and that's going to be things referred to as vasomotor symptoms, which are commonly called hot flashes. Other things that can happen are night sweats and sleep disturbances due to these. Vaginal atrophy and mood swings. So those would be the three major things that drugs currently are trying to mitigate. Symptoms are most prominent during the last 2 years of perimenopause, hormone replacement therapy, there's a lot of benefits there, and there's also a lot of risks. So we'll talk about the differences and where you might want to use it. Okay, so when it comes to menopausal hormone therapy, it does play an important role in symptom management, generally not recommended for prevention of chronic diseases associated with menopause. So they've looked at, the reason I put that in there, they've looked at whether or not supplementing estrogen and progesterone products is helpful for preventing things like osteoporosis or other things. We've talked about that a little bit with osteoporosis, probably the one example where there is some evidence, but there's a lot of other things that they've looked at. We'll talk about the studies out there that just haven't shown that giving steroid hormones is all that beneficial. I think when they first came out, there's this rush of use of them, and they thought they're going to be the next great thing, and ultimately we've realized that they really just help with symptomatic relief. That's their major role. So we'll talk about that, and they're effective for that. However, there are risks associated with that. Okay, who are we treating? Usually perimenopausal women with moderate severe vasomotor symptoms who will need to treat with a systemic hormone. We have some other options we can try and treat for the vasomotor symptoms, but really once you get to a certain severity, it's difficult to do anything with the alternative options that aren't hormonal. So that's pretty much what we end up with. Patients with no history of breast cancer or cardiovascular disease. So if you have a history of either one of those things, you're excluded from this. And if you just have vaginal atrophy as your primary complaint, then a local vaginal-only product can be useful for those patients. Those should have very little systemic side effects and be pretty well tolerated for most people. All right, so benefits of estrogen therapy. Relieves genitourinary atrophy, relieves vasomotor symptoms, helping improve sleep and other things. Osteoporosis associated with menopause, reduction in hip vertebral fractures by about 25 to 50%. Reduces rate of resorption. However, it doesn't restore bone loss that already exists. We talked about this a little bit with osteoporosis already. Cholesterol, CHD. So there's once thought that estrogen was going to be great for women because it was going to lower cholesterol, lower LDL, and raise HDL. However, it wasn't actually shown to have any long-term outcomes for various cardiovascular risks. And there's this HERS trial, which was a big landmark study in 1998. That showed that, and also the Women's Health Initiative was a big thing published in JAMA, looked at a number of women's health topics, and we'll talk about that in a little more detail, but also showed that it wasn't shown to lower any type of heart disease. Mood changes can help to stabilize that, and sexual function can help with vaginal atrophy, and therefore decrease intercourse-related pain. Risk of estrogen. Endometrial cancer risk increases with unopposed estrogen. So in a woman with an intact uterus, you shouldn't use unopposed estrogen. You're going to use a combination product. And if somebody has a history of endometrial cancer, you certainly aren't going to use it. If somebody's had a hysterectomy in the past, that might be an option for them versus using the combination product. Breast cancer. Avoid or uncertain risk with unopposed estrogen. There is some thought that it might increase relative risk by 25%, but there's some conflicting evidence out there. Generally, the consensus is to avoid estrogen if there's a history of breast cancer. Cardiovascular outcomes. We're going to talk about the Women's Health Initiative here in a second, look at some of the stuff that they looked at and get into that. General health or general adverse effects of estrogen. We already talked about these: bloating, headaches, breast tenderness, most common one. And if unopposed estrogen, you can have some unpredictable bleeding. We usually associate that with progestin, but it's also the same thing if you just have an estrogen product on board. All right, so the Women's Health Initiative looked at, again, a number of things with respect to different areas within important parts deemed by the trial designers for women's health initiatives. And they looked at a number of different studies and basically did several different meta-analyses. And a couple of the things looked at specifically hormone replacement. So what we're seeing here is these are all risk factors or these are all diseases that they compared with taking hormone replacement therapy. And you have heart attacks increasing, relative risk, breast cancer, strokes, blood clots. So several things that make you maybe a little bit hesitant to prescribe estrogen to a patient. However, when we look at the absolute risk, again, 7 per 10,000, 8 per 10,000, 8, very low cases, not like huge numbers there. The biggest one would be blood clots, which isn't unexpected there. Hip fractures actually saw decreased cases. Again, small absolute lower numbers, but still decreased. And colon cancer decreased cases. They did look at an over 65 subset of women to see if it had any effect on dementia, and actually seemed to have a 105% increased chance of causing dementia. 23 more cases, so a substantial increase for whatever reason of causing, I guess, correlating with dementia symptoms. Okay, so adding progestin to an estrogen component. Benefits: decreased risk of estrogen-induced irregular bleeding, endometrial hyperplasia and carcinoma, protection against breast carcinoma, enhancement of estrogen prophylaxis and osteoporosis. Risks: adverse effects, bloating, weight gain, irritability. So you get some more mood-related symptoms with the progestin component. And during the first 8 to 12 months, you get more unpredictable bleeding after that. However, depending on how long you're going to use it, that might be the duration of your treatment. So it's not the greatest thing in the world, but that's not uncommon to see that, and then it should subside over time. So what products are they available? So there's a lot of different delivery routes. All of them treat vasomotor symptoms except for the vaginal-only products. Now that gets a little confusing because there are some vaginal-only products that are designed to deliver systemic, kind of like the new brain type concept. It's going to deliver a systemic steroid, but it's also going to help with the vasomotor problem. So when we talk about like the vaginal-only products, I'm not referring to the systemic ones. I'm talking about like the creams and suppositories, things like that, that are just really topical more so. Unopposed estrogen therapy may cause endometrial hyperplasia and cancer after as little as 6 months of therapy. So again, I'll say this a couple times. The second time I said it, don't use unopposed estrogen in somebody with an intact uterus. It's not recommended. Okay, here's a bunch of the different products, and I'm not concerned you know the differences in these. Like on an exam, I'll tell you I'll specifically say like a vaginal-only product or a cream, or I'll specifically say what it is when I'm referring to it. So you don't have to know all these brand names or anything like that. There's a ton of different products out there. It's kind of like oral contraceptives where there's a lot of different brands, combinations, and different products that are being used. You'll notice some of these are the same thing. Estradiol, ethinyl estradiol is used in here. Drospirenone, again, used. So there's a lot of it's the same drugs, just different doses. And sometimes it's not even all that different. But generally what you see is higher estrogen components, right? 1 milligram versus we're talking about like 30 micrograms in oral contraceptives. And the progesterone components are usually going to be higher doses too. So that's the big difference here is the dose. What else about this? So some of the stuff over here, there's patches. You have twice weekly patches that might be more convenient for patients. There's estrogen-only patches, combined patches. There's gels that are transdermal gels, so that would actually absorb systemically. Sprays that absorb systemically. Intravaginal rings that absorb systemically. And then you have these products that are going to be only vaginal ones. So it gets confusing, right? Because you have two different vaginal rings, the FEM ring and the S ring. and they do different things, right? One's systemic, one's not. So it's a little bit confusing, but like the esterase creams and the tablets are going to be, that are inserted vaginally, are not going to be used for vasomotor symptoms. Yes?
How are these different than oral control?
Most of it has to do with dose, yeah. And some of it's type 2, for example, like Premarin uses conjugated equine estrogen that they isolate from mare's urine. So it's a little bit different. It's not quite synthetic in all cases. And again, it's usually dose, so much higher doses of estrogen and much higher doses of progesterone for the most part.
For oral.
For all of it, yeah. It's going to be the same.
No, for oral contraceptive.
Oh, compare, yeah. Hormone replacement therapy, higher doses than oral contraceptives.
Oh.
Yes. So like if you look at the estrogen component here, 1 milligram of estradiol versus 30 micrograms for an oral contraceptive. Okay, again, somebody who has had a hysterectomy unopposed estrogen is fine, and in fact would be preferred over somebody or over using a combined product because they're just not going to have the same side effects at all with it. They should tolerate it quite a bit better than a combined product. For most people out there who still have an intact uterus, estrogen plus cyclic progestin is going to be the common one, and which gives you continuous daily estrogen, and you get progestin for 10 to 14 days per month. It's similar to the female cycle with withdrawal bleed each cycle as well. So it's kind of like the same strategy for oral contraceptives. The cyclic nature of the progestin is quite a bit different usually there. You don't have it as continuous as you would have it for an oral contraceptive. So that's another big difference between how it's dosed and what drugs you're giving at what time. You can also have a continuous daily estrogen and progestin without interruption, although this is less common. It tends to have more irregular menstrual cycles for the 8 to 12 months, so the cyclic ones are usually more preferred for patients, but they are available in both ways. Intermittent progestin and estrogen is just continuous estrogen daily, 3 days on progestin, 3 days off. It's rarely used. It was kind of an older strategy, and again, the cyclic ones are the more common ones now. Monitoring, breast exams, mammographies, vaginal bleeding would be the common things to look for with respect to preventative care for these people on these types of therapies. Duration of therapy, usually the idea with anything, use the lowest dose for the lowest amount of time, right? But usually during that late perimenopausal phase, kind of the last 1 to 2 years is probably where you're going to be looking at targeting. Could be different depending on the patient for sure. But after a year of therapy, I would say check to see if you can discontinue it. Once the patient is through menopause, they shouldn't really need it anymore. They might need, the vasomotor symptoms should be weaned off or down by that time or gone completely ideally. They may need a vaginal product at some point as well in case they're getting continued atrophy that way, but that would be a different treatment strategy. So the systemic thing, usually you aren't going to need it for more than a couple years, and definitely usually not more than 5 years. More than 5 years of therapy would be really odd for a patient. It's recommended not to give it for more than 5 years, mostly due to the risks we talked about, cardiovascular and breast cancer related. Okay, what about non-hormonal options? So we studied SNRIs that have been probably the most common medication class to be looked at, and SSRIs actually probably work too, but it seems like the norepinephrine-containing ones are a little bit better than they're just serotonin cousins. So venlafaxine, fluoxetine, and paroxetine, and sertraline have all been pretty well studied. Now, interestingly enough, some of these products have been rebranded. So, for example, fluoxetine's been on the market for a while, and it's generic, whatever, it's been generic for decades. And so Serafem is a product that is fluoxetine that came out as a branded product at a slightly different dose, but it's just more expensive. So, be careful. I'd recommend not prescribing those weird brand names because your patient might end up paying more money because it is a slightly different dose. So look at the dose and pick the generic option that's closest to it when you're prescribing these products to people. Any of them are probably okay. Again, the evidence might lean a little bit more towards the SNRI, venlafaxine, but any of them might be worth a shot. Generally, these are used at lower doses than we'd use for depression. But you can always increase the dose and see if it helps with the symptoms if you're getting a good response. Herbal and natural products have some evidence. We talked a little bit about black cohosh. Soy isoflavones have actually similar effects to conjugated equine estrogen, and that's something that kind of going to mimic that. So it could be an option for some patients. Again, it's basically kind of like estrogen, so I don't know if you probably don't want to give it to somebody with an intact uterus. Evening primrose rose oil has been something that I don't know if that's more of a wives' tale or a traditional thing, but they've looked into that and there's no evidence that that helps with anything. Black cohosh we talked about a little bit during the supplements lecture, has somewhat effective with some evidence for it. Bioidentical hormones have similar effects to conjugated equine estrogen, and that is going to be a product that's really only used, so that's, somebody is going to be getting that from a specialty compounding pharmacy that's going to be making it. So those don't exist commercially. I'm not exactly sure how they isolate them, if they isolate them from people or exactly how they get them or how they purchase them, but it is basically just hormones. It's just not synthetic. Others, clonidine, magestrol, gabapentin have all been studied at decreasing vasomotor symptoms, and they all have kind of mixed bags of evidence. Could be tried, but not the greatest evidence out there for them. All right, talk about breast cancer very briefly. Any questions on hormone replacement therapy? All right. For breast cancer, I'm not going to go into a ton of detail because the therapies get really confusing, and what I'm going to focus on is the hormonal aspect of it because I don't really want to get into the chemo part for advanced breast cancer. Most frequently diagnosed of all cancer types out there, so this is a big one, and I think it deserves a little bit of our time just because it's such a common cancer. Leading cause of cancer-related death in women, leading cause of death in women ages 40 to 49. And so just like any cancer, we're going to look at surgical, radiation, and chemotherapy options as all of the things are on the table. So with stage 1 and 2 breast cancers, you're looking at, generally speaking, small tumors, no lymph involvement. Surgery alone can get about an 80% cure rate. If you have lymphatic system involvement, 6 cycles of cyclophosphamide, methotrexate, 5-FU, there's some different regimens. And again, I don't want to get into this. I'm going to talk a little bit more on the hormone part. So you would start with some sort of standard chemotherapy regimen. You might have heard about things like HER2 receptor positive. If your tumor specifically has a certain subset of receptors that are considered HER2 positive, you can use a biologic product called Herceptin in addition to some chemotherapy. So there's some other options out there, but again, I'm not going to test you on any of that. Hormone manipulation, let's talk about that a little bit. So you're usually going to manipulate somebody's hormones for about 5 years. And estrogen plays an important role in hormone receptor positive breast cancer and as an adjuvant and even in metastatic disease for those patients who have that. So even in advanced stages, you might still consider hormone manipulation, although at that point it's a little bit more severe, so you don't really know if it's going to help as much. Tamoxifen is an older drug called Soltamox is the brand name. It's a selective estrogen receptor modulator. You might remember this drug class as Evista or raloxifene, which was used for osteoporosis. Similar type, just different estrogen receptors it's selected for. Binds to tumors and other tissue targets, decreases DNA synthesis, and inhibits estrogen effects. Also can compete with estrogen for binding, and it causes your cancer cells, remember all the way back to first semester, your cells will accumulate in the G0 and G1 phases. And again, these are going to be for hormone receptor positive breast cancer patients only. It's not cytotoxic, so it's not going to kill the breast cells, but it is going to be cytostatic and prevent the tumor from growing further. It's quite cheap as far as chemotherapy goes, which is almost something that never comes in the same sentence together. So there's that. It's been around for a while, and it's still a useful chemotherapy option today. Side effects, you do get hot flashes, vaginal dryness, low libido, mood swings, and nausea. And if close to menopause, it might actually induce menopause to start, which is why those symptoms are there. Very similar. So tamoxifen, for example, is a summary. So good effects, it can reduce breast cancer risk, lower LDL cholesterol, and strengthens bones, like the other SERM raloxifene would do. However, it can increase uterine cancer risk and increase blood cancer risk. So, and SERMs do different things depending on which subset they're targeting. It's going to be different than raloxifene. Okay, hormone manipulation continued. Aromatase inhibitors prevent peripheral conversion of androgens to estrogen. They're contraindicated in premenopausal women with intact ovarian function because you actually get increased estrogen function due to negative feedback loops. Okay with ovarian suppression. If you use them and you're okay suppressing the ovarian function totally, that could be an option potentially, but generally speaking, somebody with an intact ovarian function, we aren't going to consider them. Examples, letrozole, anastrozole, and exemestane are all fairly expensive brand name products used for this. There's not really any data to suggest one's better than the other. Usually you start after the course of tamoxifen is completed. So start with your tamoxifen and then do your aromatase inhibitor. Side effects, you get some cardiovascular risk, increased osteoporosis risk, and myalgia and joint pain are quite common with these medications. Other things, ovarian suppression agents, GnRH agonists can be used for causing an initial release of luteinizing hormone and follicle stimulating hormone. Chronic administration causes sustained suppression of the pituitary gonadotropin, so you're basically suppressing that axis. Goserelin is the drug here. It's a sub-Q injection. It's expensive. Estrogen receptor antagonist is another medication called fulvestrant, which is a newer drug. It causes a low dose, or causes a dose-related downregulation of estrogen receptors and inhibits tumor growth. It's an IM injection once a month. It's very expensive, and you can combine it with aromatase inhibitors. So it's another one that's being used to manipulate hormones in a slightly different way compared to our standard of care. So as far as like exam goes, I really am not going to ask a ton of breast cancer questions because I think it's kind of complicated. I didn't really go through the actual how you would treat somebody because again, it gets complicated and it's definitely not my realm of expertise. So what I'd like you to do is just be able to identify like the mechanism behind tamoxifen, understand a little bit about how it works, and then also know aromatase inhibitors. I'm not going to ask you about any of the medications on this slide. So the other related therapies, don't worry about those. Just focus on the aromatase inhibitors, and if you can recognize the names of them and know what they do generally, the basic mechanism, you should be okay. Okay, stage 3 and 4 breast cancer, it's challenging, it's often palliative. Most stage 3 and 4 cancers have some sort of metastases going on. So you can use the stage 1 and 2. The hormonal therapy might work okay, but usually you're looking at other broad spectrum agents in addition to that. And its remission rates are quite low, just like with any advanced stage cancer. All right, that's it.